In this skin and soft tissue infection lecture, we're going to cover the stuff that goes deeper than the skin. We want to talk about cellulitis, osteo, and then the life-threatening diseases of skin. The superficial stuff like lice and fungus will be covered in dermatology. The backbone of all of this is going to be cellulitis. That is the infection of the sub-Q tissue. And cellulitis, infection of the skin, infection of the sub-Q, is generally caused by either Staph aureus or strep group A. And the patient is going to present with a red, hot, and tender skin. It's usually well demarcated and has a site of entry. And the diagnosis is completely clinical. You need no workup for cellulitis in order to treat it. Specifically, the way you can get tripped up is by trying to culture it. In infectious disease, you know that you should start with empiric therapy and follow up with cultures and sensitivities. So you may be tempted to get a swab of the skin to get to culture cellulitis. Don't do it. There's lots of organisms on your skin, and if you just swab the skin where it happens to be red, you're probably going to get polymicrobial. It won't be useful. Cellulitis itself is often a clinical diagnosis without ever getting the biopsy, without ever having the culture. What it's going to look like is someone comes in with a puncture site, and they've got this area of redness around it. The only clinical clues you have to really guide you are going to be the fact that staph likes to burrow. Staph goes in. That is, in staph, there's probably going to be an abscess. And if you have an abscess, a collection of pus, that you can culture. But strep likes to go out. That is spread superficially, and so there will be no abscess. It's really hard to tell them apart, strep and staph. But you know that what should happen is after you initiate empiric antibiotics, you should have a recession of the ring of red. A failure to resolve the cellulitis means you have the wrong antibiotic or there's something else underneath it. So you, as the medical student who sees a patient's cellulitis, should immediately take a pen or a marker and mark the ring, mark the edge of the cellulitis. Because when you come back in 5 hours after the dose of antibiotics, or you come back the next morning, what you want to see is the ring of erythema pulling back away from your marker line. The treatment for cellulitis has a lot of options. And you first want to break it down into whether the person is toxic or non-toxic. Non-toxic means no sepsis. Toxic means sepsis. And you've got to choose between strep and staph. Strep is generally covered by first-generation cephalosporin, like cephalexin, and Staph aureus can be covered orally with trimethoprim sulfa, Bactrim, or clindamycin. If somebody is toxic, though, that they have cellulitis and are actively septic, you're going to pull out a bigger gun. You're going to use IV medications where non-toxic patients got oral. And for staph, you're going to pick Vanc, linezolid, or Clinda. If they improve after IV medication, you can transition them to oral. Now you may be tempted to pick something for strep coverage also, something like Piptazo, Zosyn, or ampicillin clavulanate, Unison. That's okay so long as you don't also pick something for MRSA. So based on the prevalence of microbiologic data, you can choose either IV antibiotics against strep or IV antibiotics against staph, and generally the where you're going to go on the inpatient rotations is either Vanc or Clinda. It's not inappropriate to pick Piptazo, but in someone who just has cellulitis and no other risk factors, doing vancomycin and pip/tazo is overkill, unless they're a diabetic. So, if you've got cellulitis and they're diabetic, they've got a diabetic foot ulcer, that person likely would benefit from broad spectrum initially because they're polymicrobial. And you want to make sure the person does not have osteomyelitis. The person you suspect osteo in is going to be the person who fails to improve. We spend a lot of time on cellulitis because you're going to see it a lot. Cellulitis is just infection of the skin. So if someone walks into clinic, doesn't have a fever, and is like, hey, I've got an infection on my skin, you give him some cheap, really early, low on the antibiotic ladder, oral antibiotic. Have him come back. Generally going to be strep coverage. If it doesn't work, you can say, okay, well, you're still not toxic, but cellulitis looks bad. Let's try to cover for staph. Trimethoprim sulfa, Clinda. That doesn't work. All right, failure of outpatient therapy, need IV antibiotics. It's probably staph. You need some vancomycin. Or the person comes in, wow, you're really sick. You have cellulitis and you're septic. Admit you immediately. And since the prevalence of MRSA is so high, let's start with IV vanc. Chances are on the test, IV vancomycin is going to be wrong because you're going to want to pick something like clindamycin, which you can easily transition to something else. So there's two clinical scenarios. The person who progresses through clinic, not getting better, finally needs IV antibiotics, versus the person who is septic, who's toxic, who needs to come in and get IV antibiotics right away. All right. But we said we need to make sure they don't have osteo. So, osteo. Infection of the bone. You can either get that way through hematogenous spread or through direct inoculation. That is, someone gets stabbed with a penetrating injury to the bone. The patient you suspect osteo in is going to be someone with a wound where you can probe bone. You literally put a stick or a piece of metal. If you can touch the bone, they have osteo because that bone has been exposed to the outside world, skin integrity broke down. The other person you should consider this in is someone who has recurrent or refractory cellulitis. Cellulitis should be treated in 5 to 10 days. The cellulitis that keeps coming back over and over and over again, or someone has bone pain, or you just can't get rid of the cellulitis, even though you've tried lots of antibiotics, that someone is someone you should suspect osteo in. If you see a sinus draining tract or probe to bone, the diagnosis is done. You don't need any radiographic tests. But if there's good skin integrity, then you do. So the diagnosis is going to be made first with an x-ray, and know the limitations. X-rays are generally not positive except after 2 weeks. So they take a long time to show the bony changes of osteo, so they are non-diagnostic. But if they're positive, you don't have to do anything else. If the x-ray is negative, another radiographic test you could use is the MRI. And this is the best radiographic test. So if you're really worried about acute osteo and the x-ray is negative, pick the MRI. The other tests you could do that are also radiographic are going to be the tagged white blood cell scan, which is always the wrong answer, so don't do that, or the bone scan. The bone scan can give you inflammation activity in the bone. So long as there's no superficial inflammation, that is, there's no cellulitis, the bone scan can work. So if the test gives you suspicion for osteo and no overlying soft tissue inflammation, bone scan okay. But I'm going to cross the line through it because it's very rarely the case. So the tests you want to use are x-ray. If it's positive, great. If it's negative, it means nothing. And the MRI, which is a best radiographic test. The absolute best test is a biopsy. Either debridement or a puncture. You take the bone, make sure that it's dead, make sure it's infected, and grow a culture on it. And the reason why you have to be so considerate of the culture and making the diagnosis appropriately is because the treatment for osteomyelitis involves debridement. Remove the bad bone, and then 4 to 6 weeks of antibiotics. You'd like to be able to tailor your antibiotics to that biopsy. If you don't, you might be left spending 6 weeks on vanc and pip/tazo. way too broad spectrum, especially if you're a diabetic with a diabetic foot wound. If you can't get the antibiotic to cover the specific bug, you have to go broad and go broad for 4 to 6 weeks, which is generally too long. And as you follow them, what you're going to want to do is follow up with an ESR and a CRP. Eventually, you'd like to transition to orals. And so as you continue to manage these patients, you give them IV antibiotics, hopefully get to an oral combination, and follow the ESR and CRP. And as the ESR and CRPs fall to normal, you know you've treated the osteo. But it's important, you only make the diagnosis once with MRI or the biopsy. You don't do those again as the treatment continues. If osteo, then yes, and follow up ESR and CRP while they're on long-term antibiotics. So cellulitis and osteo, you're going to see a lot. On your inpatient medicine months, you're going to see it. The stuff you may not see that gets talked a lot about, so probably is going to end up on the test, are the dangerous ones, like gas gangrene and neck vac. Gas gangrene is caused by Clostridium perfringens. Not C. diff, that's diarrhea, C. perfringens. And the patient is going to present with a penetrating wound that got somehow contaminated. So think of the hunter in a swamp or at a construction site or feces. So somebody has some sort of penetrating wound that gets contaminated, it's really dirty and nasty, and then you feel crepitus. The bone's not broken, there's just air in the sub-Q. The diagnosis begins with an x-ray. And the x-ray is going to show you gas. If you see gas on the x-ray or you feel crepitus, the treatment is going to be debridement. You'll see how frustrating this becomes in a minute. But if the diagnosis is gas gangrene, you're going to pick a penicillin plus Clinda. And clindamycin is chosen because this is a toxin-producing organism. Clindamycin turns off the 50S ribosome, no more toxin gets made. Great. Watch the similarities between this and neck vac, at least as they are as you say them out loud. Because they look very different in reality, but the way they are described both in textbooks and on the test is very similar. The problem with necrotizing fasciitis is that it's caused by the same bugs that cause cellulitis, and it looks like a cellulitis. It's caused by strep and staph. If you have neck vac on the groin, it's called Fournier's gangrene. The same disease. It just happens to be in that place, and that's where our genitalia is, so people are hypersensitive about it, especially since the treatment for necrotizing fasciitis is generally debridement. The patient is going to present with cellulitis, but there's going to be cellulitis and something else. It's not the normal cellulitis. The person's going to be really toxic, not just a little septic, but super sick. It'll be rapidly spreading, where there'll be a failure of the antibiotic to recede off the line, and you're just going to say, oh, well, maybe I've got the wrong antibiotic, but they're going to be really ill. And if you see either pain out of proportion with the physical exam or crepitus, there's that crepitus again, I want you to think necrotizing fasciitis. What you might see on the test is blue-gray discoloration. If you see the words pain out of proportion or blue-gray discoloration on a cellulitis question, it's neck vac. The first thing you do is get an x-ray, and it will show you gas. So you see the crepitus and the gas are present in both gas gangrene and necrotizing fasciitis. But the contaminated wound is gas gangrene, whereas the typical cellulitis that's doing something weird is more likely to be necrotizing fasciitis. The treatment is immediate surgical debridement. This usually allows you to get a biopsy also to prove that it's necrotizing fasciitis and hopefully get the cultures and sensitivities. The antibiotic regimen you're going to pick in the hospital is going to be broad spectrum. You will pick vancomycin and pip/tazo. That's totally okay because these patients are very ill and you want broad spectrum, cover everything. But for the test, that's going to be wrong. What you want for the test is a third-generation cephalosporin plus Clinda, again to turn off any toxin production, plus ampicillin. This becomes a good test question because the empiric coverage for super sick is a little weird. Even though you want to do more than this, this is what they'll give you. So vancomycin and pip/tazo will be wrong on the test, but it's absolutely right to do in life because you're covering broadly because the person's so ill. Okay. And then the last thing I want to close with is just nitpicky memory stuff. You have to know it because they're great pimp questions. So what I want you to link in terms of cellulitis and osteo is the clinical scenario with the likely bug. The most common cause of osteo is Staph aureus. The most common cause of osteomyelitis in any clinical setting is Staph aureus. It's just that when you have a risk factor, the number 2 organism becomes more likely. If you see this organism, think this disease. It is tricky because if they give you a risk factor and staph is sitting there, it's still staph. If you have sickle cell, think salmonella. If you have a penetrating wound or any mention of a sneaker, it's Pseudomonas. If you have a diabetic foot, you should think polymicrobial. What you're going to cover for is Pseudomonas. And this is where it's okay that if you have a diabetic foot ulcer, you give them vancomycin and pip/tazo or some other anti-pseudomonal because you're covering for MRSA and Pseudomonas. If you see the word oyster or cirrhotic, it's actually the 2 together, but the vignette might only give you 1. I want you to think Vibrio vulnificus. This kills people, so cirrhotics should not be eating raw oysters. And lastly, if you see gardening, think Sporothrix. Except for this last part, which is pure memorization, I want to review one more time. Cellulitis is going to be red hot, well demarcated lesion on the skin, generally with some sort of penetration of the skin. If they're not that bad, pick something oral. If they're really sick, pick something IV and then de-escalate. Watch out for diabetic foot ulcers and osteomyelitis because they add a level of complexity. Osteomyelitis is generally non-toxic, so you have time. Get the biopsy, confirm the diagnosis, and get the sensitivities going before you give antibiotics. If they are toxic, give antibiotics before the culture, knowing you may contaminate the culture. Probe to bone, recurrent refractory cellulitis, bad wounds, think osteo. To diagnose, X-ray, if that's negative MRI, definitively with the biopsy, and you're going to have to treat for a long time to cure osteo. Gas gangrene is penetrating wound that's contaminated, crepitus and gas, penicillin Clinda. Necrotizing fasciitis is cellulitis that's really bad, pain out of proportion, crepitus, blue-gray discoloration, gas, debridement with a 3rd-generation cephalosporin plus clindamycin plus ampicillin. That is skin and soft tissue disease.